All right, so we're going to move in to the systemic fungal infections with the classic pathogens, histo, coccidio, and blastomycoses. So I'm going to introduce them in general at first, and then we'll talk about each one of them specifically. What's going to be really important for diagnosis in a lot of these is geography, okay? So pay attention to the region of the country where you'll typically find these. That's going to be a big clue, okay? Now, what's interesting is that most of the time when a healthy person comes in contact with the systemic fungal infections, it's asymptomatic. Now, a few people will present with an acute pulmonary infection, or it may perhaps go chronic. And then, of course, what we really worry about is a disseminated fungal infection. That typically is going to happen in someone that's immune compromised. All right, diagnosis, again, sputum cytology. And what that is what I referred to previously with sporotrichosis. If I told you that you found cigar-shaped yeast in a sputum sample, that's the sputum cytology. And that's going to be important as well for the systemic fungal infection. So we're going to know what the yeast form looks like. Okay. Now, the histoplasma, because it targets the macrophage, can also be detected through blood cultures because it resides in the macrophage. So you can actually do a peripheral blood culture to look for histoplasma. So we're going to start with talking about histoplasma. Again, I'm showing on the top the environmental form, which are referred to as hyphae with macroconidia, okay? And the bottom, I'm showing the yeast form. Now, you may not know what to look for here, but I'm going to outline this with the pointer. You've got a nice little unicellular cell here with a nice big nucleus. It's not a neutrophil, it's typically a macrophage. And you can see all of these little organisms inside each one of these are the intracellular yeasts. So histoplasma, a little bit more difficult to pick up because they're very small intracellular yeast. There's not like a BAM flash word that I can give you to help you with the diagnosis there. Again, I said geography is going to be extremely important. So what are the endemic regions for histoplasma? We're talking about the Ohio-Mississippi River Valley, okay? So you can see that in your book. You can kind of see where that falls in the United States. The main association with histoplasmosis are people that are associated with bat droppings, bird droppings, okay, and people that move, let's say, from the West Coast into the endemic area. So let's look at some specifics for the organism and how you acquire it. Sometimes the disease is called spelunker's disease. And what spelunking is exploring caves. And what are you likely to find if you're exploring caves? Lots of bats. And what do bats have to do? Like the rest of us, they have to go to the bathroom. So you're going to walk through that cave, you're going to inhale that bat feces, and that's how you're going to get histoplasma. Additionally, chicken farmers also have a high incidence of histoplasmosis. When I first started teaching medical school, we were teaching in Kentucky, and one of my students was very excited because he had diagnosed a histoplasma case, and the physician wasn't really sure what it was, but the student knew because we had just finished this section on fungal infections, and he just happened to randomly ask the patient, you know, what do you do for a living? He said, oh, I'm a farmer. And he said, really, what kind of animals do you have? And chickens was the big one, okay? So that also can be a pretty good indication for you. Again, the tissue form, small intracellular yeast. May be very difficult for you to see, but they may describe it. We found small intracellular yeast within macrophages. And as I showed you before, when we outlined these cells, if you look at all those tiny yeast in there, you can see that you can get 30 or more yeast in one human cell. So they're really packed full of these tiny little yeasts. Now, what are the diseases? Again, a lot of the times these are asymptomatic, but you can have a pneumonia with flu-like symptoms. How are you going to know that it's histoplasma over some of the other agents, bacterial pneumonia and viral pneumonia, for example? Well, clearly one of the clues is going to be geography, or maybe cave exploring, or chickens, okay? Another clue is maybe the patient comes in, he's got these flu-like symptoms with pneumonia, and you started them on antibiotics, and they're not working. The patient's actually getting worse, or at least not feeling any better. That might be one indication for you that you may have one of these systemic fungal infections. Now, you can also see hepatosplenomegaly, and as I mentioned, this is common in newcomers to that area. So you move from one area of the country or the world to that Ohio-Mississippi River Valley, and it might be fairly common for you to get histoplasmosis. The lesions do have a tendency to calcify as they heal, and that's going to be important when I talk about some of the opportunistic fungal infections. When histo disseminates, as it does frequently in AIDS patients, it disseminates to mucocutaneous sites. So you will develop mucocutaneous lesions with histoplasmosis. So the disease, again, is sometimes called the fungus flu. You can have a pulmonary presentation with dissemination to the mucocutaneous sites. Now, with T-cell immunosuppression, which is required for treating fungal infections, especially with intracellular yeasts, of course this is going to be worse and disseminated. The treatment for all three of the systemic fungal infections is going to be amphotericin B. So you're going to hear me say that over and over again. You can use ketoconazole as well for treatment for histoplasmosis. Okay, moving on to the next of the dimorphic fungi. We're going to talk about Coccidioides immitis, which causes something called desert valley fever. Now, the environmental form, the hyphae here, are referred to as arthroconidia. You inhale the arthroconidia, and at body temperature, you get the yeast form, which I'm outlining here. This yeast form is called a spherule. Okay, so a spherule is diagnostic for coccidioides, which is also called desert valley fever. So again, region, geography is going to be important here. You're in the desert Southwest, you're in Arizona, New Mexico, etc. If they put that in the question, that's going to be a big clue, okay, that you might have coccidioides. Now, again, the tissue form is going to be the spherule. Now, again, being a computer-based exam, they can either tell you that they found spherules in the sputum, or they can show you an image. So you want to have kind of a good idea of what a spherule looks like. Now, what's the disease? The disease is actually, again, an acute pulmonary disease, can cause pneumonia, all right? And actually, in the endemic area, this is said to be very common. I have a friend who's a cardiologist that actually did a pulmonary rotation out in Arizona, and he said that 1 out of about every 4 patients they saw had coccidioides or desert valley fever. So in that area, it tends to be fairly common, whereas in other areas of the country, you're not going to really suspect it at all. Okay, so it's very common in the endemic region, and again, those pulmonary lesions have a tendency to calcify as they heal. Dissemination in AIDS patients, it will disseminate typically mucocutaneous lesions, or it can cause meningitis. Now, this also has a tendency to disseminate in the 3rd trimester of pregnancy. And what we'll talk about when we address the immunology portion is that pregnancy creates an overall status of immune suppression so that the mother does not reject the fetus. Okay? It's not as severe of an immune suppression as, for example, in AIDS, but pregnant patients should be considered, for all intents and purposes, immune compromised. So it can disseminate in pregnancy, particularly in the 3rd trimester. How are we going to treat it? We already mentioned with amphotericin B as the drug of choice. Last on the list for the systemic fungal infections is blastomyces dermatitidis. The name itself, dermatitidis, okay, should tell you where it disseminates. Now, the environmental form don't have a good picture for you, but again, it's the yeast form that really matters. So here is your broad-based budding yeast. Remember, all of the B's for blastomyces, broad-based budding blastomyces. They can mention that in a case, which they often do, or they can show you an image. So here's your budding yeast with a broad base here, and you have kind of a double refractile cell wall around those budding yeast. What is it associated with? They're thinking probably rotted wood. So something like that can come from an association with beaver dams. But the absolute association is not definitive. So what's the endemic region here? Very similar to histoplasma, but it goes further north up into Canada, and it goes a little bit further south. Okay, so it does follow that Ohio-Mississippi River Valley, but it extends a little bit further on both ends, more so than histoplasma. Again, here's your tissue form, your broad-based budding yeast, and again, you should be able to recognize an image of that, or you should understand the description of that. Now, the diseases for blastomyces are typically considered less likely to resolve than histo and coccidioides, but you can see the dissemination here to the skin. So dermatitidis, we're disseminating to the skin in both of these cases. Okay? So blastomyces dermatitidis is going to disseminate to the skin. The other two typically will disseminate to mucocutaneous lesions. And again, we're going to treat blastomyces with amphotericin B. All right, that brings us to our final group of fungal infections, the opportunistic fungi. Where you're going to see the good majority of these show up is in AIDS patients, okay? A lot of the fungal infections, the parasitic infections, are going to show up in AIDS patients. So a lot of what you're expected to know for USMLE as far as HIV is concerned deals with a lot of the opportunistic infections that those patients are going to get. So we're going to look at the fungal infections. Not all of them are associated with HIV, but Candida, Cryptococcus, and Pneumocystis certainly are probably one of the top 3. So we're going to start by talking about Aspergillus, and the species is Aspergillus fumigatus. And again, it's all about the morphology for diagnosis for the fungi. So what you want to remember for fungal infections is that Aspergillus is at an acute angle, typically about 45 degrees. So if you were to make the peace sign, that's the approximate angle that you're going to see Aspergillus. Now, Dr. Barone, who sometimes does the pathology, I learned this from him. I told him I would always give him credit if I used it. So here it goes. How do you remember it? You've got the 45-degree angle, and Mr. California says, A, Aspergillus, 45-degree angle, man. So that was for you, John. Okay, they're going to put that in the question, 45-degree angles with septate hyphae. What does that mean? The hyphae are actually divided. So there's little divisions in the hyphae. That's important because there's another one we're going to talk about that have non-septate hyphae. Aspergillus, unlike the systemic fungi we just talked about, is monomorphic. So you're always going to see it in the fungal form, which again is at the 45-degree angles. Now, the diseases are different that can be caused by Aspergillus. There is an allergic type reaction called allergic bronchopulmonary aspergillosis. And what happens here is typically farmers will start to inhale a lot of the mold, for example, in the hay, and they will develop kind of an allergic reaction to Aspergillus. In preformed lung cavities, like what might be left over from tuberculosis, you get what's called a fungus ball. So you have a preformed cavity in your lungs left over from a previous disease. You inhale some Aspergillus, it gets into that cavity and forms what we call a fungus ball. And you need typically surgical removal to get rid of it, but you can also have hemoptysis with the fungus ball as well. So it can actually mimic a little bit like tuberculosis. The most severe is invasive aspergillosis, okay? Invasive aspergillosis occurs in people that are usually severely immune compromised. And once this occurs, this is a really nasty one to get, because once the Aspergillus gets in with little to no immunity, it invades very, very quickly like any cell or tissue that it wants to go in. So it can invade and cause myocardial infarction. It can invade the nasal mucosa, can cause pneumonia, meningitis, etc., and is very, very nasty and very, very difficult to treat. All right? So that brings us to treatment, in which, again, the drug of choice is amphotericin B or itraconazole for Aspergillus. The next of the opportunistic fungi we're going to talk about is Candida albicans. Candida is a very important opportunistic fungi, not only in AIDS patients, but we're going to see it crop up in a lot of different specific instances with specific comorbid conditions. So it is sometimes referred to as a normal flora. Some people hesitate to say that we have yeast as part of a normal flora, but we do, and Candida is one of those yeast. As far as distinguishing features for Candida, what I'm showing in this image is the formation of germ tubes. So you have the yeast, and it will actually form these germ tubes if you incubate them at 37 degrees in serum. All right? They also can form pseudohyphae and hyphae when they invade tissue. Now, I don't want to confuse you and tell you this is a dimorphic fungi, because I gave you the four most important. In fact, this is dimorphic in a little bit of a different way, because it's pretty much the exact opposite. And when you get into the body temperature, you start to get reversion into this fungal form. All right? You can still see yeast at body temperature, okay, but it's still dimorphic. It's not necessarily based on temperature like we saw with the other ones, but again, we can go from a yeast to something that has pseudo and true hyphae when it invades the tissue. So what are the different diseases, okay? In the crevices of the mouth, you can have Candida infections. Oral thrush is a big one, especially in AIDS patients, along with esophagitis. Thrush is also very common in infants, particularly premature infants, and it can also be in immune-compromised patients. Now, before we talk any further about the diseases, what are you going to see with a Candida infection is you're going to see it described as a cottage cheese type of discharge. So if we're talking about vaginitis, it's going to be a cottage cheese-like discharge. If we're talking about a skin infection, you're still going to see that white Kurdish-like material, but there's going to be a lot of erythema there. So there's going to be a lot of redness, and there's going to be a lot of itching. Now, Candida can also cause gastritis, sepsis, and endocarditis as well, typically in IV drug users or, again, immune-compromised patients. In addition to thrush, what's very common for Candida infections are cutaneous infections. And where are we going to see these? We're going to see them in people who are diabetics, You can see them in obese patients. You can see them in pregnant patients. And where they're going to thrive is where skin touches skin. That creates a nice, warm, moist environment for Candida, and it grows very well there. Vaginitis, very common. We talked about Gardnerella in Chapter 2 causing bacterial vaginosis, but in addition to getting BV post-antibiotic therapy, you're also highly susceptible to a yeast infection as well, because when you disturb that normal flora, the yeast are just going to thrive. The most severe of the Candida infections is something called chronic mucocutaneous candidiasis. And this typically happens in people with not only endocrine defects, but can happen in people with T-cell defects or defects in cell-mediated immunity. And it tends to be a chronic infection. It infects all the mucocutaneous sites, and it's really, really nasty. CMC is one of the diseases you'll see in DeGeorge's syndrome, which is when children are born without a thymus, so they have absolutely no T-cell immunity. They get plagued with chronic mucocutaneous candidiasis. Now, how are we going to diagnose it? We can do KOH, but most of the time what they're going to say in the vignette is they're going to say cottage cheese, discharge, lots of erythema, and they may tell you about the germ tube formation if they culture that at 37 degrees in serum. How are we going to treat Candida? We're going to use over-the-counter topical antifungals like nystatin, for example. But in the case of disseminated infections, you have to go with amphotericin B or fluconazole. All right, the next organism we're going to talk about is Cryptococcus neoformans. Cryptococcus, remember, is the C. In the mnemonic we used earlier, some killers have pretty nice capsules. So let me show you the image here, which you have a yeast that is surrounded by a nice thick capsule. The yeasts are monomorphic, so they're not going to change. They're not a dimorphic fungi, but they're monomorphic yeasts that are very heavily encapsulated. They are associated with pigeon droppings. So people that are around a lot of pigeons, like in New York City, in New York, people call them rats with wings. You can go with that because you won't get Cryptococcus if you stay away from those pigeons. Now, the additional thing I want to talk about is that is the most common cause of meningitis in AIDS patients. Okay? Now remember, we had Listeria monocytogenes, which was the most common cause of meningitis in renal transplant patients and cancer patients. And most of the time when we say most common in immune compromised, that includes AIDS, and usually AIDS is the predominant one we're speaking of. But here it is different. So we have Cryptococcus neoformans as the most common form of meningitis in AIDS patients. Now, how are we going to diagnose it? We're going to look for that capsule. Are we going to use India ink? Probably not, because it misses half of the cases. So we're going to use latex particle agglutination for diagnosis. You can culture it, and it's actually urease positive. So you have a urease positive yeast. So that's an important feature about Cryptococcus. Now the treatment is a little bit different, all right, for Cryptococcus. You have to use amphotericin B and flucytosine until that patient is afebrile and culture negative, and then you have to treat with fluconazole. So it's a multiple drug regimen, and it's usually for a longer period of time. Again, mostly we're talking here about meningitis. All right, the next opportunistic infection on our list are the mucor species, or rhizopus, or absidia. These fungi are non-septate, meaning if you look, you follow the arrow along the hyphae, there's no septate divisions in the hyphae. And these are typically at 90-degree angles, all right? So you have a hyphae with 90-degree angles, no divisions in the hyphae. So sometimes that is described as a ribbon-like hyphae. So you have a 90-degree angle, ribbon-like hyphae. That's going to be mucor or rhizopus. What is the specific infection here that we're talking about? Only affects a very small patient population in that it really targets ketoacidotic diabetic patients, okay? Also patients with leukemia. And what happens here is you inhale the organism and it is so invasive, it basically goes right up through your nasal sinuses and starts to attack your brain, okay? So it is extremely invasive and destructive. There was actually a story not too long ago on CNN called A Man Without a Face. It was a ketoacidotic diabetic patient who was one of the few who has actually survived an infection with mucor, but in the process it took away most of the structure of his face, took away his eyesight, and so in order for him to really go out, they developed a mask for him in which, in the bone that he had left in his skull, they implanted magnets, and then they had a little facial mask that was magnetic, and he could put on when he went outside. But most people don't even survive infections with mucor. So they penetrate very easily, and one of the things I'm going to point out that will help you in the diagnosis here is that these fungi are dark colored. So if you have a case of sinusitis with mucor rhizopus, one of the things they're going to tell you in the vignette is that they have black pus. So the drainage from that sinusitis is actually black. All right, diagnosis goes back to what the hyphae look like, 90-degree angles, ribbon-like hyphae, so no septal divisions. How are we going to treat it? We're going to use amphotericin B as soon as we can. We're going to debride the tissue, but most of the time patients don't survive infections with mucor. Now, the last of the opportunistic fungi we're going to talk about is Pneumocystis jirovecii. This was also one that had changed its name, and you may have been taught about Pneumocystis as Pneumocystis carinii. And so it got the name PCP pneumonia, which stands for Pneumocystis carinii pneumonia. Now we've changed the name to Pneumocystis jirovecii, but we still call it PCP pneumonia. Okay? So these are fungal infections that are really an opportunistic infection, one of the leading causes of death in AIDS patients. And if you look at the organism, you'll sometimes see, depending on the book that you read, you'll see them described as a dented helmet. Now, I'm not sure what a dented helmet is, but as I'm looking at this, it looks like a condom. So if you see something that looks like this in a tissue biopsy, that's when you're going to know that it's probably pneumocystis. All right, so in AIDS patients, again, one of the leading causes of death, usually when the T cell count dips down very low, so we're talking below 50 here. Okay? What are you going to have? You're going to have pneumonia, basically. You've got fever, shortness of breath, and a non-productive sputum. Now, as far as the virulence is concerned, you're going to be damaging the respiratory tract and the alveolar epithelium. So some of the other pathology tidbits that can help you with the pneumocystis question are, number one, because the serum leaks into the alveoli, when you do a hematoxylin and eosin stain, you'll get a characteristic foamy or honeycomb appearance, so that can be helpful. Or on your x-ray, you get what's called a ground glass appearance on the x-ray. Now, they may mention that in there. They may ask you specifically about that, but most of the time with a lot of the opportunistic infections, they're going to ask you about the diagnosis in somebody that's immune compromised. All right, so diagnosis, we're going to do a bronchial alveolar lavage or biopsy, and you're going to do a silver stain, and you're going to find those little condom-shaped cells within the tissue. How are we going to treat pneumocystis? We're going to try really hard with trimethoprim, but again, in AIDS patients, this is usually the leading cause of death. So a lot of the times in full-blown AIDS, the treatment is not always going to be successful. So that concludes Chapter 5 of the medically important fungi.